The treatment outcomes for relapsed and primary refractory AML are generally dismal. Unfortunately, in AML as a whole, despite the enormous amount of progress that we have made in understanding the biology of leukemogenesis, particularly in the last 10, 15 years, and despite the development of a number of exciting target-specific agents, we haven't had any new drug approvals. Hopefully that should change in the near future with some of these trials that are positive moving on to the regulatory agencies. In terms of the overall population of AML, we still are highly dependent on cytotoxic chemotherapy for treating patients, even when the new agents are approved and available. They're likely to be combined with traditional cytotoxics. And vosaroxin is a general anti-cancer quinolone derivative agent that has significant topoisomerase 2 activity, and because of that is of a lot of interest as an anti-leukemia agent. It also is of interest because it has limited toxicity in terms of non-bone marrow-related toxicity, and this is because of data suggesting that it produces less reactive oxygen species, and because of that is less cardiotoxic. As such, it's an interesting drug, particularly in the relapsed AML, because these patients have already received prior anthracycline-based induction and consolidation therapy. The VALOR trial was a large multinational, multi-institutional, randomized controlled placebo trial where the objective of the study was to see if the addition of vosaroxin to higher dose Ara C is superior to Ara C alone in primary refractory or first relapsed AML. The choice of Ara C is because Cytarabine or Ara C is the best available anti-AML agent. The study accrued 711 patients who were stratified based on age and duration of first remission, and randomized to receive on a one-to-one basis either the vosaroxin or the placebo in addition to cytarabine. The original or the primary analysis was reported 2 years ago at this ASH meeting, and the data was also published. Using the unstratified analysis, the overall survival was not superior for the vosaroxin population with a p-value of 0.06, although the stratified analysis did show an advantage. More interestingly, the advantage appeared to be completely confined in the older patient population. This was a pre-specified analysis, and patients over the age of 60 actually comprised 2/3 of the patients enrolled on the study, 450 patients. And even in that initial primary analysis, there was a statistical advantage in terms of response and survival for the patients randomized to vosaroxin. In this year's ASH, we are presenting data on the further follow-up of these patients with a median follow-up of about 40 months, so longer update in specific older age group, patients over the age of 60. And data shows that the advantage for vosaroxin is stable over time, and with the longer follow-up, the patients who received vosaroxin had a better survival, statistically significantly better survival advantage than the placebo arm, and in fact the p-value improved with the further follow-up. So it shows that in this population of patients over the age of 60, clearly the drug is a useful agent to add to cytarabine-based salvage chemotherapy. And the other thing that I didn't mention is that the early mortality, 30-day and 60-day mortality, is the same in the two arms of the study, despite the fact that vosaroxin is a cytotoxic agent and is associated with more infections and mucositis.